You're listening to the Pelham Podcast with Tony Kay, the show that highlights all things Pelham Medical Center.
So we're here for another episode of the Pelham Podcast, and really privileged to be joined today by Dr. Amy Curtis, who's a radiation oncologist with the Gibbs Cancer Center, and Michael Starnes, who is the executive director of Gibbs Cancer Center operations, has a background in radiation himself as a physicist. And these two, along with other people in the organization, really make the Gibbs Cancer Center quite exceptional for the community the size of Spartanburg to have the depth of resources we have. So really honored to have y'all here today. So I want to jump in a little bit, let the audience know maybe a little bit about you. Dr. Curtis, maybe if you want to give a little bit of your history, why you got into medicine, and how you may have ended up here in Spartanburg.
And after residency, came straight here. So I'm excited to have been a part of the Gibbs Cancer Center now for 15 years.
Okay. Yeah, so you knew what you wanted to do when you were growing up.
I did. I know lots of people take winding paths, but I've been fortunate that mine was pretty straight.
Good. Michael, what about you?
Mine was a little more winding, obviously. Degree in biology, wanted to get into some sort of medicine, but not necessarily medicine. Went to MUSC, College of Health Professions, got into radiation therapy, pulled into medical dosimetry, which has a strong physics background, which is one of my strengths. And if you stay here as long as I've been here, which is be 27 years in June, you slowly get pulled into administration. And then you get pulled further into administration and further into administration. So no more time in the clinic. But again, it's been a long and winding path to kind of get me to where I am now.
Well, and glad to have you here. Not a lot goes on without your hands on it. So you're an important part of the team. Maybe you'll have different perspectives given your length, Michael, 27 years, and you, Dr. Curtis, 15. But tell us a little bit about, the history of Gibbs, how things came to be, and how we got to where we are now.
Sure. So the original cancer center in Spartanburg started in the 80s, and it moved out of radiology down into a small facility where it stands today. I came in 97, and we immediately started on a project to open the large cancer center that's in Spartanburg now. That opened in June of 1999. It was our first really effort to kind of become a comprehensive cancer center, offering all the services under one roof, bringing in medical oncology, who had previously been in a different site. Radiation oncology is part of that as well, surgical oncology. Then we started to expand out into other holistic type things like let's take care of the nutrition and the well-being of the patient, have social work on site. Talk about financial things with the patients, looking at oncology rehab. Dr. Curtis will actually expound a little bit in a minute about clinical research. Huge piece of what we do. Clinical research is really ingrained into everything that we do every day. We want to make sure that we offer the best, high-end science for our patients as they go through their cancer journey. In 2020, we came out here to join you guys at Pelham, and March of 2020 was really not a great time to open a cancer center. We were open for about 6 days and the whole world shut down. But again, bringing those services out here was a big piece of what we wanted to do. We had a nice hospital out here. There were growing services out here, making sure that we expanded on what we were already doing. Our footprint out in the Western Division was important, and actually growing that moving forward. So we built a really nice facility across from the hospital here, about 200,000 square feet. And some pieces of that are shelled, and we'll kind of get into later why we have those shelled. But growing out here is kind of a growth market for us, and we know the population out here is ever expanding, and being ready for that is going to be key for us moving forward.
Very good. Dr. Curtis, you have interesting viewpoint on the history of the Gibbs?
Yeah, so in addition, as Michael mentioned, to growing our footprint and our facilities at Pelham, in Gaffney, and in Union, we've just had a lot of programmatic growth. And I think that what happens in the clinic, in the room with the doctor and the patient, and making sure that those services are growing is much more important than what happens with the glass and steel. And it's really an outward manifestation of the quality and the programmatic excellence that we have inside the building, that we have somewhere beautiful on the outside.
Yeah, and I think you make a great point that the organization has made a real concerted effort to have a very in-depth cancer service. This is not just a few infusion bays and we do some radiation. I mean, this is pretty in-depth. So to help our audience maybe understand, would either of you classify sort of the structure of the way we deliver all services, pre-cancer all the way to treatment, as sort of an academic model, or would you consider it to be something different?
It's kind of a hybrid model, honestly. We are a very big center that is based in a small community, but we also bring in highly trained physicians from academic facilities to work here. Clinical trials, again, is a piece of that. Academic facilities will definitely focus more on research. They're going to focus on making sure the newest trials are available to patients. But we have a little bit of an academic flair as well. Our former VP, David Church, used to say all the time, we're a community cancer center with an academic flair, and we really are. That is kind of who we are, making sure that we provide excellence in care, not just necessarily the standard of care, and continue to do the same thing. We're always looking for the next thing. And much like an academic center, you do that through hiring really intelligent people like Dr. Curtis and other physicians, because they know the newest technologies and the newest techniques.
Yeah, so let's maybe explore a little bit about, again, the depth of things. You know, when somebody presents with a cancer case, you guys operate what are called multidisciplinary conferences. I think that it's easy for the patient to see that they're getting a chemo treatment or they're getting radiation or they're visiting with a doctor and they see the beauty of a building. What everybody might not understand is really what goes on to try to deliver the best outcomes for a patient. So talk to us a little bit about the concept of a multidisciplinary conference and how someone who presents with a cancer case gets evaluated to deliver the best course of treatment.
So we have 11 multidisciplinary planning conferences that we regularly conduct. Some meet every week and some meet twice a month, depending on the volume of cases and our expertise availability. And we try in those conferences to match the medical recommendations with the patient's values. And so that's where our social workers and our navigators, having met the patients up front and knowing about where they come from and what things are important to them, are also considered in the treatment recommendations that come out of that. And it's amazing to have everybody together once a week for an hour, reviewing the radiology, reviewing the molecular testing, reviewing recommendations for genetics and oncology rehab, because our goal is not just to treat the cancer, it's to make the patient able to achieve their goals, whether that's taking care of grandkids or taking a big trip or going to learn a new skill. And I think our rehab component is really important to helping patients achieve those goals. So they are really an important part of that. Research is a part of our multidisciplinary planning conferences, whether it's new treatments that are disease-directed or symptom treatments. So a lot of our cancer treatments still have a lot of toxicities, and so we're very mindful of that, even in our planning conferences. What's the most effective and least toxic way that we can treat a cancer to have the patient meet their functional goals as well as their oncology goals?
So it's clearly a lot more than just going straight to a surgery or some kind of intervention. So maybe we'll play this out for the listener. So let's say somebody presents to one of our providers with colon cancer. Talk to the audience a little bit, without obviously giving individual patient information, just about how a colon cancer patient might be discussed globally. I think what a lot of people outside of healthcare would be fascinated to know all the various discussions and decision-making that goes in, because there's not one perfect way to treat a patient, and you guys are trying to find the best way to treat that individual patient.
That's right. And things have gotten much more complex and personalized. So it used to be kind of a 5-centimeter tumor was going to get XYZ treatment. But now you could have a 1-centimeter tumor or a 5-centimeter tumor, and depending on the molecular signatures and the patient's genetics, they could have a completely different treatment path. And that's why we have specialists. So our oncologists, several of them are GI oncologists, that they're not seeing every cancer under the sun. They really are spending the majority of their clinic time seeing patients like that, so that they're able to provide the most nuanced recommendations. Of course, we're informed by guidelines, and we really benchmark ourselves with national guidelines and national quality indicators. But you can't treat a patient based on a strict algorithm, that you really have to have a nuance, especially with new medicines, immunotherapy, targeted therapy. If somebody has seen dozens of patients like that, you're going to have a higher quality than a patient is seeing a doctor who's seen 1 or 2 a year.
I'll also say, for the average person, a good way to think of the multidisciplinary conference is it's a huge second opinion for you. And what I mean by that is you're seeing your primary care physician or your primary oncologist, your specialist. And a lot of people like to go out in oncology and get a second opinion. And we encourage people, please go get a second opinion. We can be your second opinion and we'll refer you somewhere else for one. But when you're in that room, typically there's going to be 1 or 2 radiation oncologists, 2 to 3 medical oncologists, several surgeons. There's going to be specialists related to clinical research. There's going to be specialists related to navigation, maybe imaging specialists. You're going to have a pathologist, a radiologist. All those people are weighing in on your case. So when the physician comes to you and says you were presented at the multidisciplinary planning conference, you can have the confidence that probably 12 to 15 physicians have reviewed your case together and had conversations about you, which really gives you kind of a ease of mind that, you know, I can go for a second opinion, but I've already had a multitude of people look at this. So it's a really nice way to have peace of mind that the care plan that the physician has for you is going to be the right one. Now, to Dr. Curtis's point, she has this phrase that I say she coined, which is we're going to do some shared decision making. And that essentially means she's going to take those recommendations back to the patient and they're going to make that decision together. Ultimately, it is the patient's decision what we do as far as treatment. But again, and Dr. Curtis can tell you, every patient will look you in the eye and say, what would you do if this was your family member? And those discussions happen all the time. But that shared decision-making between the patient and the physician cannot be trumped by anything. It's a good conversation between you based on evidence-based medicine and what the patient's preferences are.
That's a great explanation. I, watched a couple of, or participated just as an observer to a couple of these multidisciplinary conferences. I was fascinated, particularly as a non-clinician, at the fact that everybody speaks up. So it may be a surgical case, it may not, but the surgeon's perspective is helpful to the pathologist, to the radiation oncologist, to the medical oncologist, so that a recommended course of treatment can go along with what the patient's wishes are. It's pretty fascinating to watch. And I think the ability to be collaborative that way, again, in a community the size of Greenville and Spartanburg, that we have that kind of depth is really special. And that's really what makes, I think, Gibbs a special place. Is it's beautiful, but we're going to take care holistically of you. And a lot of people are making a decision about or a recommendation for your care. I actually hadn't heard that comment before, Michael, that you're basically already getting multiple second opinions after you go through that. That's pretty cool. Talk to us a little bit about, after that happens, what would the care delivery process look like? I mean, obviously that depends on what the intervention might be, but how do we go through the care delivery, along with the fact that we have other resources? We have patient navigators, social workers, other people to help the patients navigate their whole experience.
Right. And I think our care delivery is our people. And we have fantastic technology. We have robotic surgery. We have CyberKnife. We have Savvy. We have amazing technology, but our people are really our special ingredient. And the fact that when patients walk through the door, they see the same faces over and over again. Our infusion nurses, our radiation therapists, the nurses in the surgical office, there is not much turnover. And so patients really, really feel cared for as a person when they get care here, because our people are very mission driven. Many of them have had family experiences with cancer and really feel called to come and work in an oncology setting. And they get to live out their mission of helping others, whether that's in nursing or in pharmacy, whether that's our patient access representatives that are at the front desk registering patients. They really want to be helping cancer patients. And you can see that when you come through the doors.
I have definitely witnessed it firsthand, just having the benefit of working here. And the privilege is a lot of what you said around being able to care for people. But my father-in-law had some cancer issues, and I've witnessed the description you just gave. I mean, I get that I work here, and so you have the luxury of knowing some folks, but he got an appointment through the urologist, and watching a discussion with the providers and a recommended course of treatment. And his had progressed enough to where they were just trying to get him therapy so that he could just live a better life. And unfortunately he couldn't, but just, I will say, the care and compassion, and particularly when he was going through the end, that the physician caring and compassion was about as high as it could be. I mean, just really special again, and what makes me proud is that we're not a huge healthcare system, almost 2 billion, but we're pretty large. But again, the depth of resources we have for something like cancer and your ability to respond to people quickly, like you said, weekly multidisciplinary conferences, you hear that word, that's not something you want to sit on. And the responsiveness you've built in, but the entire course of care navigation is pretty special. So I witnessed that firsthand. Maybe you can explain or maybe dictate how some of the outcomes at Gibbs might stack up against the quote unquote renowned facilities. How do our outcomes here stack up against, organizations that might be renowned nationally?
Well, we are very rigorous about benchmarking with our peers and also people we consider leaders in the oncology field. And we have excellent outcomes as far as overall survival, local controls, surgical infection rates, things like that. Our benchmarks really are within the same confidence interval. The other thing I'll remark on is the fact that we look at those centers as collaborators and they look at us as collaborators. So in the past year, I've gotten emails from Vanderbilt and Wake Forest asking for our expertise on conducting clinical trials and reaching rural and underserved populations, African American population, because our population, we do a great job serving them. And so many times those centers are looking for community partners to learn best practices from as well. We've got members of our community that have sat on national task force and advisory boards and given lectures about the care that we give here in the community. So we benchmark against others, but other people are benchmarking against us as well.
Yeah, that's pretty special.
And I'll say data is only good if you use it. And internally, we look at our data all the time. Dr. Curtis and I are about to review the 5-year survival rates for all the different disease sites in the next week or two. Taking that data and letting it drive what you do strategically from a planning standpoint is a huge deal. And Tony was in a meeting recently, so was Dr. Curtis with us with SG2, which is one of our outside consultants, where we're actually looking at data and trying to let that guide where we're going clinically. That data will tell you what your community needs if you pay attention to it. And looking at things like lung cancer and the incidence of lung cancer in our area and what are the survival rates, it tells us we have some work to do there. So how do we do that? We take our financial resources and address that by increasing low-dose CT screening, hiring staff to actually help and manage a nodule clinic to address things that they may need. So using that data and leveraging it towards what we can actually do for our community is making it actionable and actually something that will help our community long term.
Yeah. I definitely have seen that firsthand. You're seeing that building come out of the ground and the future capacity we have to grow into whatever the needs might be is exciting for the community primarily. I mean, we get the privilege of working here, but the community has an option to stay locally. If there are subspecialty treatments that they can't get locally, that happens. I've got a friend whose daughter has a glioblastoma and she's gone through some stuff at Duke, but they've developed some techniques and tools there to remove it best they can. And the treatment she got has staved it off. So she's living a normal life. But most of the stuff can be done here. And it's wonderful, particularly when you have multiple infusions or multiple radiation treatments, that you can do it locally. It's a burden on the family if you have to travel a variety of places. Let's talk a little bit about research. I think it's probably something that the community at large would associate only with a very large academic medical center. So talk to us a little bit about our research, what it is that we do, and what's the benefit to the patient. You alluded to a little bit earlier some patient benefits, but what's the benefit to the patient of our research programs?
Sure. So our research program started in the 1980s. We've had a formal relationship with the National Cancer Institute for 40 years. So again, even before there was a building out of the ground, there was a program with expertise and national recognition about our oncology research program. Most of our research is conducted through the National Cancer Institute and cooperative groups that have funding through the National Cancer Institute, but we also have pharmaceutical partners for various treatment trials and disease sites. Our research program spans the spectrum, so we have a large study going on right now for breast cancer screening. So even before there's a cancer diagnosis, we want to be part of the conversation on developing better screening for one of the most common cancers. We have treatment trials. So is infusion A better than infusion B, which is what most people think of with clinical research. We have symptom management. So we have a large survivorship population, and those patients are served with clinical trials for insomnia, fatigue, neurocognition. So patients complain about chemo brain or chemo fog. And we have research studies for that, shortness of breath and distress. So things that are addressing our survivors' needs as well. So we really have a fantastic portfolio from screening all the way through treatment and survivorship. And like I said, many partners nationally and in industry.
Is there maybe one facet of research you might highlight around a product that SRHS and the Gibbs were instrumental in getting to market or supporting? Because obviously our patients benefit by having access to trials, but has any of our research led to any breakthrough? I honestly don't know the answer.
So that's a great question. So we actually were a participant in STAR, which was a study of tamoxifen and raloxifene way back when. And now we think about tamoxifen as, like an old drug for breast cancer, but it's been on the market and has saved countless lives. And, we were a part of that. I'm one of many, 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 many people that was a part of that.
Right.
Immunotherapies, targeted therapies, we've been part of those studies, which is really exciting. And because our cancer center, it has such a strong research infrastructure, our whole health system has benefited. There was a recent study published in the New England Journal of Medicine on the Eat, Sleep, Console for neonates with opioid addiction. And our NICU had that study open because we have a research infrastructure. And so our residents, our pediatricians, our neonatal intensive care unit nurses got trained on that protocol, which shows that this protocol for infants does better than giving them opioids and is now the national standard of care. But we had it here first because we had the guardrails for research, we had consent and partnership with parents, and we have that culture here.
And I'm certain that a lot of people in the community don't know that or appreciate the fact. Again, it goes back to the depth that y'all have created. This probably wouldn't be a good discussion if we didn't at least bring up the venerable Drs. Bearden and Josie. Dr. James Bearden is a medical oncologist. Dr. Julian Josie, who's since passed on, viewed as the founders, if you will, of the program. Jimmy Gibbs is a local philanthropist, businessman who certainly has contributed in many ways to help get the Gibbs off the ground. But talk about the influence and work of Drs. Josie and Bearden and maybe the influence they've had on y'all.
It's really hard to put all that into words, quite frankly. The Gibbs Cancer Center doesn't exist without the two men. And their relationship with Jimmy Gibbs has been extremely instrumental in everything. If you want any evidence of that, our breast center is named the Bearden Josie Center for Breast Health. People in the community think so highly of them that they donated enough money to build this facility and didn't even name it after themselves. They named it after those two physicians. It was really nice to work with Dr. Josie for the 20-something years I worked with him. You're working with somebody important when the CEO of the hospital comes down to meet with him in his office. And he listens to Dr. Josie, and Dr. Josie has his ear. And they're always trying to push for the next best thing. And Dr. Josie's number one thing that he used to always tell me was, if you always put the patient first, any decision you make, you can defend. There is nobody can come back to you and say, why did you do this? I put the patient first. And he always did that. And part of that was really going out and hiring really smart, intelligent people. And I'm sure Dr. Curtis can elaborate on her relationship with him.
Yeah, I think their biggest contribution is the culture that we have, the culture of putting patients first, the culture of being embedded in the community. I think we are the beneficiaries of the Gibbs generosity. Billy Webster, Lindsay Levine Webster, the Montgomerys. Betty Montgomery is on our foundation board and is really a leader in community engagement. And I think that the fact that we're here and serve the community and serve all members of the community is an important part of the culture that they established.
And I appreciate y'all's insight because my time here is 11 and a half years. And again, these kinds of services with depth are typically associated with big cities and larger healthcare systems. And it's living proof that if there's a viable vision and you have the right stakeholders who have grit, you can make something happen. And they certainly created something along with a whole lot of other people, and they'll be remembered for generations because of what they were able to bring to their hometown. And again, not to have people have to leave for a level of care that they can get here locally. It's quite a legacy. It's also a great validation of system leadership over the years, 40 years of supporting a vision and providing the resources, manpower, and again, many of the what I'll call not directly caregiving or clinical in nature. There's a whole lot of wraparound services you mentioned with the navigators and other things that make the program successful. It's not just the chemo infusions or the surgery or the radiation treatments, it's the whole team. And that's what is really special to me, having come here from a larger city, that the depth here is pretty special.
It really is. And I think, the fact that we're embedded in the community, that I may be treating somebody this year and 3 years from now, that person may be teaching my child to read. And that there's a level of respect between our patients and our doctors and a level of teamwork. We're really all in this together. Really, of course, we all have boundaries, but the fact that we share a common goal is so important in what we do.
So, Michael, you earlier mentioned a commitment to offer the services as the community's needs arise. One of the things you mentioned was lung cancer. Talk a little bit about some of the things that Gibbs is doing around lung cancer.
So one of the biggest initiatives we have right now related to lung cancer, which is our number one focus right now, it's really circled around low-dose CT screening. For those that don't know what that is, based on your smoking history and your age, you may qualify to have a low-dose CT screening. A good way to think of it is mammography. Most women over the age of 40 need to go have a mammogram yearly to assess their risk, or if they actually have something in their breast that might potentially be breast cancer. Historically, back in the 70s and 80s, before mammogram became prevalent across the country, we found more later stage breast cancers. Now, if you walk through the front door of the cancer center, your 5-year survival rate for any stage breast cancer is going to be about 92%. That's kind of where we sit right now. Lung cancer is really not that great. And I won't get into the exact numbers, but it's not good because we typically find our patients showing up in the ED and they're coughing up blood. They've had this cough that's been persistent for 6 months. They have other issues. How can we address that from a front end rather than from a back end perspective? And the way that we do that is if you qualify to have a low-dose CT, you can go have a screening each year. And the idea being is we want to find that small cancer when it's the size of a pea rather than the size of an orange. And finding a smaller tumor earlier allows people like Dr. Curtis and the medical oncologists and the surgeons to address your cancer at an earlier stage, and your outcome is going to be better. So the growth of our program around that has been really huge. 2018, 2019, we were doing about 600 of those per year through education for our primary care physicians and education of the outside public. We're going to do about 4,200 in 2023. And in 2024, that number is probably going to be somewhere around 5,000. Now, keep in mind, that also doesn't count for the fact that we have another 10,000 patients who do qualify that should be getting a low-dose CT. The goal being we want to find your cancer early because if we find it early, we can treat it and your life expectancy is going to be better.
That's a 5-fold increase in really just a few short years of that kind of prevalence. That's pretty striking. I know every cancer case is different, so I'm a little apprehensive to ask, but I'll ask anyway. If you do find a lung cancer early, is that something that often can be treated without a surgical intervention? I know it's dependent on the patient, but...
It depends on the patient, but typically for lung cancer, early stage it is treated with surgeries. And then if it's more advanced, it's radiation and chemotherapy. Again, the earlier we find it, the more options we have and the more time that we have. If somebody is in crisis, like Michael said, coughing up blood, we really are not going to have time for sending somebody for a second opinion. There's not going to be time to evaluate for a clinical trial to the same extent as somebody has been mowing the lawn the day before and feeling good and really robust to tolerate a wide variety of treatment options. So finding them early gives patients not only the greatest chance of survival, but the greatest chance of having a less toxic treatment.
And in our case, we're the beneficiaries, again, of adding services over the time. We have excellent cardiothoracic surgeons who I assume in many cases are the surgeon of record, although people may choose to go other places.
That's right. Yeah, our thoracic surgeons are fantastic. And going back to the benchmarking, low leak rates and infection rates, long length of stay, all of those metrics about outcomes are superb for our surgeons. And going back to non-invasive, we have a CyberKnife radiosurgery platform. So there are some lung cancers that can be treated precisely. They're with low toxicity and just 5 treatments. There are more advanced cancers where we need to do 6 weeks of treatment. But again, we're able to conform around the esophagus and the heart to treat the lung cancer in a way that's less toxic to the surrounding organs.
And we mentioned the CyberKnife. We've had that technology here for the listening public is radiation therapy, but maybe talk a little bit because we're really one of very few in the Southeast that actually have some of the latest technology in CyberKnife.
Yeah, we were one of the first places in the state of South Carolina to have a CyberKnife. And for the people listening, the basic way to think of a CyberKnife is if you've ever seen one of those commercials where they have a robot that welds a car together, it looks very similar to that. It's an articulating arm which has 6 degrees of freedom. The table also has 6 degrees of freedom, so it can go left, right, up, and down, plus do some twisting and some pitching and yawing back and forth. But that CyberKnife allows us to deliver ablative doses, so doses that are almost equal to very precisely, because we image during the treatment to make sure that we're hitting the right spot. And it's delivered over a very short course of therapy. So unlike traditionally when I would plan a patient for Dr. Curtis 15 years ago, they would get 30 fractions of radiation. They're getting almost an equivalent amount of dose over the course of 3, 4, 5 days. And so because of that, patients are very drawn to a quicker resolution of their care, which is a great way to get your care done. CyberKnife treats a lot of lung, it treats a lot of prostate. We also do metastasis in the brain. We'll do small lesions. It does have limitations. Obviously, we're not going to treat a huge area in a patient, but typically things around 4 or 5 centimeters we can handle inside the patient. But that technology has been here now for 10 years. We were the first place in the United States to have the M6 version, which is what we have, which has a multi-leaf collimator, which allows us to be a little quicker and more nimble with what we do. Very high tech.
Yeah. It starts with low tech, though, getting patients in for a low dose CT. And then the very low tech is getting patients to quit smoking. And we have a really robust smoking cessation program. We're persistent about our offers. We call, text, and email patients that smoke and offer to connect them with services. We try not to be too intrusive, but to let our patients know that we want to partner with them to quit smoking.
So for those of y'all listening, similar to a mammogram, the sooner that, if you qualify, if you've been informed that you qualify or you think you may have an issue, there's places you can reach out and have a screening provided to you that hopefully in most cases will give you complete knowledge that you might be cancer-free. But in the event that there is something there, it's an opportunity to catch it earlier where the outcomes are much better. So that's, again, you've mentioned community a few times, but I think the organization as well, being about the people, is what separates it, is your commitment to the community and trying to create wellness rather than simply treating illness.
Absolutely.
From the Pelham Medical Center perspective, we invested a lot of money coming out here, joining up with Pelham Medical Center. We built a 200,000 square foot facility. And what most people don't know is in that facility, there's about 60,000 square feet where we don't have anything on those floors. It's shelled space. And financially doing that, it is expensive to build those shelled floors instead of just not building floors. But the important component of that is we're preparing for the future. There's no way for us to know what physicians are going to want, patients are going to want, what new technologies are going to come in the next 20 years. And the most important thing you can have is space for those technologies when they arise. In Spartanburg, we're landlocked at Spartanburg Medical Center campus. If we don't own it, Walford does. We're just right there on top of each other. And you can go up, but it's very cost prohibitive to build up on top of a building. So we looked at population trends, and one of the fastest growing areas in the state of South Carolina is where we're sitting right now near Pelham, near the airport. And coming out here to where the population is very important. I tell people when I do tours of the facility that we built this facility not for the next 10 years, but for the next 50, 70, 100 years. And a piece of that is the community outside these walls right now. They're mostly young business professionals with children. So they're in the I'm having kids, my kid broke their arm, they need tubes type phase of life. they're already starting to transition into the age that I am, which is 51, and you need a colonoscopy, you're needing a mammogram. Over time, next 5 to 7 years, they're going to start finding things on their screenings, and we're going to need to be here for them. So preparing for the future, I think, was the big piece of coming out to Pelham, joining up with the hospital, talking about services, expectations, and what you guys see and what we see in the future. So having that space available, being in the community, letting everyone know that it's here is the goal of making that the hub of what we do moving forward.
Dr. Curtis?
I think one of our missions of Spartanburg Regional Healthcare System is to be the most trusted partner in health. And there's really a commitment from our staff and administration to provide great service to patients, because we know that patients, when they come into the emergency room with back pain or they see their primary care doctor with a cough, that most of the time it's not cancer. But we want patients to trust us so that when it is cancer, they know that they're in good hands.
You guys are just top-notch, the entire enterprise. So tell us maybe a little bit about outside of work, what you might enjoy in your life and what you do to have a balance.
So I have 3 kids, so love family activities. And then I like words. So I've been playing the New York Times Connections, and I get an email every day that's a word of a day, just for fun.
All right.
Yeah, obviously married 25 years, 3 kids, and oldest just got married. So watching him progress has been interesting and fun. Daughter's graduating college this year, and my youngest, Tony, and I talk about a lot, baseball player at Limestone University. So watching what they do is always fun. Like you say, you got to have work-life balance, and the things that happen outside the walls of this place are really important. And keeping up with those is really my primary drive in life.
We share a lot in common. I've got 3 kids myself, and they have occupied most of my time. But the reality is that's really what brings me joy, And so I enjoy hearing you talk about your son, only because I think it took my boys, they played all variety of sports. It took them until they got into their 20s to realize that my joy in watching them was not thinking they were going to get to the NFL or the NBA, but just the sheer joy as a parent of watching them have fun. And if they excelled, great. But it's really just being part of a team and watching that. So now that they've migrated out of the high school years, and 2 of them are out of school as well, and nobody's married yet, but they might at some point. Really, that's what drives me as well, is just getting a chance to spend time with family. So we have a lot in common. Good luck to you, Dr. Curtis, as you explore colleges down the road.
Yeah,
those are expensive enterprises,
Yes.
and you certainly will get to share in that joy of sending hopefully all 3 of them to school, depending on what they want to do. It is a lot of fun. It's also interesting, and I hope my wife listens to this podcast, because I too like words. I am a crossword puzzle guy, and so I'm glad to know, and Michael's given me the thumbs up, that it's like, why are you always doing that crossword puzzle, Dad? It's like, hey, I'm wanting to keep my brain sharp so I don't forget who you are one day. But
Right.
So we share that in common as well. As just there's a couple of online crossword puzzles I try to do every day, and then there's some ones that from the paper that I try to do just to challenge myself.
Yeah, it's a great way to connect. My daughter introduced me to the connections test, and so now we text each other and see who gets it and how many tries. It does make your brain work in a little different way.
It does. You got a little internal competition.
Yes.
Cannot thank y'all enough for giving some time here. It really is an honor and a privilege, because you 2 are exceptional people. I'm certain that might embarrass you, but you 2 are great examples of what the Gibbs Cancer Center really is all about. Michael, in his brain, he could have gone anywhere he wanted to. He chose to come here. Dr. Curtis, same thing. In fact, getting to know you a little bit, I know that Dr. Josie made a big impression on you. Medical school and residency, you end up getting a chance to go wherever you might fit. And so we're blessed to have you guys here, because what the community gets out of the work that you do is really second to none and stellar.
Thank you for listening. For more information, visit PelhamMedicalCenter.com.